Good morning, all. Welcome to Module 3 of Extraoral Radiographic Techniques. Coming to radiography of the mandible, it comprised of PA mandible, mandibular oblique lateral projection, that is for body of the mandible, and for ramus of the mandible. Coming to PA mandible, this projection shows the posterior parts of the mandible. It is not suitable for showing the facial skeletal because of the superimposition of the base of the skull and nasal bones. Main indications are fracture of the mandible involving the posterior third of the body, angles, ramus, and lower condylar necks, lesions such as cysts or tumors in the posterior third of the body or ramus to note any mediolateral expansion, mandibular hypoplasia and hyperplasia, and maxillofacial deformities. This is a resultant image and various structures seen. The patient is in exactly same position as for PA skull, that is the head tipped forward, the radiographic baseline horizontal and perpendicular to the film in forehead nose position. The exit tube head is horizontal, that is 0 degree, but the central ray is centered through the cervical spine at the level of rami of the mandible. Coming to mandibular oblique lateral projections. Oblique lateral radiographs are extraoral radiographs of the jaws that can be taken using a standard intraoral dental X-ray machine. Before the development of dental panoramic equipment, they were the routine extraoral radiographs used both in hospitals as well as in general practice. Equipment used are standard intraoral X-ray machine, an extraoral cassette of size 15 by 18 cm, and a lead shield to cover half of the cassette when taking bimolar views. Coming to mandibular body projection, indications are evaluation of presence and position of impacted teeth, detection and evaluation of fracture of the mandible, evaluation of lesions or condition affecting the jaws including cyst, tumors, giant cell lesion and osteodystrophies. It is an alternative when internal views are unobtainable because of severe gagging or when the patient is unable to open mouth or is unconscious. It is also used for viewing the salivary glands or TMJ. This is a resultant image and various structures seen. The head is tilted towards the side being examined and the mandible is protruded. Film is centered over first molar, parallel and 2 cm below the inferior border of the mandible. Central ray is directed toward the molar premolar region from a point 2 cm below the angle of the opposite side of the mandible. Resultant image is the image of the teeth, the alveolar ridge, the body of the mandible. If there is significant distortion, it means the head was tilted excessively. If the contralateral side of the mandible is superimposed over the area of interest, it means the head was not tilted sufficiently. Coming to mandibular ramus projections, various indications are to assess impacted third molars, large lesions and fractures that extend into the ramus of the mandible, to demonstrate the ramus from the angle of the mandible to the condyle. This is a resultant image and various structures seen. Head is tilted towards the side being examined such that the condyle of the area of interest and the contralateral angle of the mandible form horizontal line. To prevent superimposition of the cervical spine on ramus, patient is asked to protrude the mandible. The film is placed over the ramus and far enough posteriorly to include the condyle. The lower border of the cassette should be approximately parallel with the inferior border of the mandible and extend at least 2 cm below the border. Central ray is directed toward the center of the image ramus from 2 cm below the inferior border of opposite side of the mandible at the area of first molar. The resultant image should include third molar retromolar area, angle of the mandible, ramus, condyle. If significant distortion is present, the head was tilted excessively. If the contralateral side of the mandible is superimposed over the area of interest, the head was not tilted sufficiently. Now coming to radiography of the TMJ. It comprised of transcranial projection, transpharyngeal projection, transorbital projection and reverse trans view. Coming to first, that is transcranial projection. The transcranial projection provides a sagittal view of the lateral aspect of the condyle and temporal component. Various indications are temporomandibular joint pain dysfunction syndrome, internal derangement of the joint in which the signs and symptoms are pain, clicking and limitation in mouth opening. To investigate size and position of the disc, this can only be inferred indirectly from the relative position of the bony elements of the joint. To investigate the range of movement in the joint. This is the resultant image and various structures seen. The patient is placed in a craniodome with the head rotated through 90 degrees so that TMJ under investigation is touching the film and the sagittal plane of the head is parallel to the film. Initially, the patient's mouth is closed. The X-ray tube head is positioned with the central ray aimed downwards at 25 degrees to the horizontal across the cranium, centering through the TMJ of interest. The procedure is repeated with the patient and X-ray tube in the same position, but the patient's mouth open as far as is comfortable. A bite block is used for stability. The procedure is then repeated for the other TMJ to allow comparison. Again, views are taken with the mouth open and closed position using same size bite block for both sides. There are various variations for the transcranial techniques such as posterior articular or Lindblom technique. In this technique, the point of entry of central ray is half inches behind and 2 inches above the external auditory meters. The central ray should be directed from the posterior so that it passes along the long axis of the condyle. By this projection, the medial pole of the condyle is more posterior to the lateral pole. Second variation is Grewcock approach. In this technique, the central ray enters through a point 2 inches above the external auditory meters. And third approach is Gill's approach. In this technique, the central ray enters through a point half inches above the external auditory meters. All above mentioned techniques, the central ray is directed at angle of plus 20 degree to plus 25 degrees. Now coming to another projection, that is transpharyngeal projection. This is also called Palmer projection, infracranial or McCune-Dell projection. The transpharyngeal projection provides a sagittal view of the medial pole of the condyle. Indications are temporomandibular joint pain dysfunction syndrome, to investigate the presence of joint disease, particularly osteoarthritis and rheumatoid arthritis, to investigate pathological conditions affecting the condylar head, including cyst and tumor, to assess fracture of the neck and head of the condyle. This is the resultant image and various structures seen. The patient holds the cassette against the side of the face over the TMJ of interest. The patient's mouth is open and a bite block is inserted for stability. The X-ray tube is directed superiorly at -5 degrees through the sigmoid notch of the opposite side and 7 to 8 degrees from the anterior. Because of the negative beam angulation, this view depicts the mesial aspect of the condyle. Now coming to transorbital, also known as Zimmer projection. It is particularly useful for visualizing the condylar neck fractures. The entire mediolateral dimension of the articular eminence, condylar head and condylar neck is seen. The transorbital projection involves tilting the patient's head downward 10 degrees so that the canthomethal line is horizontal to the floor. The film cassette is placed behind the patient's head. The X-ray beam is directed from front of the patient through the ipsilateral orbit and temporomandibular joint of interest perpendicular to the cassette. The patient opens maximally or as an alternative protrudes the mandible, thereby positioning the condyle at the summit of the articular eminence and avoiding superimposition of the articular eminence or skull base on the condyle. The central is oriented downward approximately 10 degrees and laterally approximately 30 degrees through the ipsilateral orbit centered over the TMJ of interest. Now coming to last projection, that is reverse tongue projection. This projection shows the condylar heads and neck. The original tongue's projection, which is anterior-posterior projection, was designed to show the occipital region. But here, in order to assess the condyle, we use reverse tongue projection, hence the name reverse tongue. Various indications are to investigate the quality of the articular surface of the condylar heads in the TMJ disorder, to assess the fracture of the condylar head and neck, condylar hyperplasia and hyperplasia, intracapsular fracture of the temporomandibular joint. This is the resultant image and various structures seen. The film is placed in front of the patient perpendicular to the mid-sagittal plane. The patient's head is tilted downward so that the canthometer line form a 25 to 30 degrees angle with the film. Opening the mouth takes the condylar head out of the glenoid fossa so they can be easily seen. The central is perpendicular to the image receptor and is centered at the level of condyles. This is the resulted image, a reverse down showing compression fracture of the right condyle. This is the end of module 3. Thank you.